Okay, hi everyone, welcome to class, and let's do some little housekeeping before. So, yes, this is the last official lecture. So on Friday on the same time, so like 1:30 to 2:20 Hawaii Standard Time, it's a study day, but I'll hold an extra optional review session. So we'll cover things, and again, where can you ask questions about for the review session? So if you go to was it Top Hat, and let's go there real quick. Yeah, so if you go there real quick, and if you look at the FAQ, same thing as last time. And speaking of Top Hat, what else do we have? Oh, so all the assignments are live, and you might notice the last assignment it's actually like the semester wrap up. It's basically like, okay, it does test you on content, but it's pretty much asking you, like, you can, one, it's your little survey to kind of wrap up the semester. But two, like, if you do the survey, you get, I believe, like, was in the beginning, was it? Yeah, so if you get, like, the survey just by answering it by yourself, and again, this won't be used against you or for anything. It's just, like, just looking at overall stats and the demographics of this class and how this class, or just, like, the overall impacts of this semester. It really helps me to adjust things for future semesters, so that's why I kind of asked this at the end. And also for this like part where I'm asking you basically every single chapter we covered. Oh, I have to answer this, but there's another part of it where I ask you, okay, with all the chapters we went over, so let's see, yeah, there's a studying at home. Yeah, so basically just facts through the major topics we covered. So I mean, hopefully you learned at least one fact, even if it's a small fact, even if it's a definition, that's something you learned this semester. And that will be 70 points. So this will be done at the and the other thing about these assignments, you might have noticed that I extended them until May 13. So that's the end of finals week. And that is the absolute last day of the semester. So even though that we have our final is on May 9th, because again, that is determined by the university scheduler, the May 13th, like everything needs to be done by then. So I'm giving you until then, and the other thing is, like, it serves you best if you do it before the exam, because I mean you can do it after, it still counts for points, but if you're these are meant to help you study before the exam. And you may have noticed, like, the metabolic, I don't know why it didn't go up, like it didn't launch itself when maybe it was like something with the date. But I'm going to waive metabolism, so as long as you just do the questions, I'll give you full credit for that. So that's what will happen for the metabolism. And you may have noticed that on the grade book, if you look at the grade book, there's something called for fluids. There was supposed to be another quiz, and quiz 13 is already the reproductive system for male. Quiz 14 will be the female. And then quiz 15 will be kind of like an exam 3 review. So kind of just like for you to prep yourself for exam 3. But so you might be like, wait, so is that 16? Yeah, it is 16 because there is that quiz 00, which is the syllabus. So those are the 16 quizzes. But because we didn't get to cover fluids, I am just going to give everyone 75 points by default for that one, because we didn't have time for fluids. It's not that it's not important, but I think if you kind of understand the urinary system and blood, then the fluid chapter is actually pretty easy by itself. So hopefully your future classes will cover that if you're heading into nursing or medicine. All right. Okay, so let's finish the last content lecture of today, or of the semester. So what are we going to cover? Well, we're going to cover the reproductive systems again, but now we're going to talk about reproductive cancers. So again, 74% of you we'll cover this. So male reproductive cancers, we have to cover things like, okay, well, what are the male accessory glands what are the accessory glands of the male reproductive system? So remember that these are the ones that help to make that seminal fluid. So we have the seminal gland that produces the bulk of the fluid. You have that prostate gland with which the urethra runs through, but also this vesicle right here, the ejaculatory duct runs through that as well. So two branches that lead to the same spongy urethra over here. And then you have the bulbal urethra, or these Cowper's glands, these tiny glands that produce this small amount of alkaline mucus, but they all come together to form that seminal fluid that helps to carry or suspend sperm, but also provide some nourishment and some chemical protection and enzymes that help sperm fertilize a potential ovum. So these secretions combined with sperm make what we call ejaculate. Now the prostate gland, so we did cover that briefly when we talked about the urinary system, but prostate cancer is something that can happen when the cells of the prostate gland start to divide and in an abnormal rate. And the biggest factor with that is age. So who's most at risk of prostate cancer? Well, the median age, so if you took all the prostate cancer cases in the United States and lined them up by age and who would be right in the middle, so it'd be around 67 years old. And it's very rare in relatively young men. Why? Because if you look at the statistics, I think it was maybe 7.5 of cases are below in males that are younger than 55 years old, and I think it's something not even a percentage in in males below 45 years of age. Now there's something called BPH, so we did cover that briefly with the urinary system, but the thing is that prostate enlargement is a natural process. The prostate gradually enlarges in volume with age, and about 90%, so not a complete guarantee, but very, very common. If you don't have BPH by the time you're 70 plus and you're male, you're very lucky. So most of us will develop BPH, and BPH also causes the increase in something called prostate-specific antigen. And why do I cover that? Well, the thing is that there are many hormones involved in prostate cancer, and there's a enzyme called 5-alpha reductase, again, that ASE. Big hint that it's an enzyme. So it is an enzyme. To understand the 5-alpha part, you kind of have to know a little biochemistry. Don't worry about that for this class. But what is 5-alpha reductase going to do? It's going to convert testosterone into an even more powerful version of testosterone called DHT, or dihydrotestosterone. And why is it more powerful? Well, it activates the androgen receptor that affects the genetic activity inside cells that are sensitive to androgens. So this one is increases that genetic activity by binding to that androgen receptor even better. So then that's why DHT is more potent. And there's also aromatase in prostate cancer. So aromatase is that same enzyme that we talked about when we talked about the ovary and theca cells and granulosa cells. So what they're going to do is what androgen or aromatase is going to do is convert androgens into estrogens. So here we have androstenedione becoming estrone and testosterone becoming estradiol. So all of these will increase the growth of the prostate cancer. So if you have estrogen receptor for some reason in the prostate cancer, and that's the interesting thing about cancers, sometimes they end up having receptors and being sensitive to hormones they're not normally used to. And then also you have the androgen receptor also causes prostate cancer to grow even further. And they also have an increase in this peptide called prostate-specific antigen. So it means prostate in it. So it's a protein that's produced by the prostate gland. Now, if you have high levels of prostate PSA in your blood, does that mean you have prostate cancer? Not necessarily, because the other one, that BPH, it's benign, so that means it's not a cancer. It's a growth, and hyperplasia means a growth in that tissue, but it's not a cancer, necessarily a cancer with this. So BPH is not the same as prostate cancer. So the interesting thing is that you have increased BPH in prostate cancer and increased BPH you have increased PSA in BPH and increased PSA in prostate cancer. So how do you know if it's really cancer or not? But the thing is that benign prostatic hyperplasia is a growth, that natural growth in the prostate. So if that prostate volume increases, that's going to narrow the prostatic urethra, making it hard to micturate and void and urinate. But it also affects the ejaculatory duct as well. So that's also going to affect ejaculation. And so this is why it can be painful to have BPH, because you have this buildup of pressure in the urinary and reproductive system. So it's going to be very hard to have fluids being ejected through this prostate over here. Now, what we have with so how do you tell between the two? Well, one thing you can do without even having to do any well, it is invasive, but one thing you can do to say you have elevated PSA, one thing they can do is okay, BPH is you can tell it's the gland is increased in volume and swollen. So, but a cancer is just like that, or just like when I talked about, endometrial cancers, and so cancers, they tend to have a lot of cells packed in that tumor. So cancers tend to be denser than the surrounding normal tissue. So one big thing is like, okay, benign BPH would have an increased volume. The prostate would feel larger than normally is. But with prostate cancer, say it is in a place that can be felt, what can happen is that there can be a rectal exam, and even though it looks big in this picture, it's not very big. It's like only like at most like 2 inches. Like it doesn't need to pay you the whole finger. But what they do is like feel and whether it's like the normal texture, if there's any hard masses, and are they going to rely just on a physical exam? Not necessarily. So the thing is that you're just feeling that there is some sort of lump. So what they probably will do is take a biopsy, so a small tissue sample, and then then a pathologist will look at a microscope and see if those cells from that sample look cancerous compared to a normal prostate tissue. So what I'm getting at here is that you can't just rely on just one test and say, oh, you have cancer. You often have to have multiple tests to make sure that, okay, there is possible cancer. It's not something like BPH can be uncomfortable for the people who suffer from it, but it's like you won't want to do like full chemotherapy on someone who has BPH when they don't really have cancer to begin with. All right, so there are many risk factors of prostate cancer. So there's increase, and this is based on like the national statistics. So increased incident in black men. So they're 50% more likely to develop prostate cancer and 2 times more likely to die from prostate cancer. And more on the local, like especially men of Polynesian ancestry, they are more likely to be diagnosed with late-stage prostate cancer. So is it due to some like changes or differences in like the androgen receptor? Well, that's what a lot of cancer researchers are looking at. Is it due to some sort of change or like variant in a gene? Or is it due to some other factors? Like it's not just genetics, there's also environmental factors. So things like socioeconomic factors also affect cancer risk. And it's not just for prostate cancer, it's also for many cancers as well. So even like income and education, that affects if you have the low income or low education and low earning potential, that affects someone's access to healthcare. So this could be another reason so it's not exactly a clean break between the two, like whether it's genetic or environmental. Sometimes they build on each other, like being socioeconomic disadvantage can also compound with these factors. Now, so that was the prostate gland, but what organ is this? So this is, hopefully it's the testes. And testicular cancer is another major male reproductive cancer. So what happens is like so cancer, it starts off somewhere. These are cells that become cancerous. They start dividing abnormally, and they start to invade the surrounding tissues. So when it's localized, in terms of testicular cancer, it's still in the testes. So the testicular cancer, but the good thing about that is if it's still in the testes, is that the cancer is still there, and there's 95%, I mean not still there, but it hasn't moved past the testes, and there's a very good survival rate. So that's one thing you see with cancer is that they look at the survival rate, like, okay, follow up 5 years later, is this person, did they beat cancer, so to speak, and the cancer hasn't come back and they're still surviving. So 99% at that stage. But once it starts to spread beyond the testes and maybe toward the inguinal area and the lymph nodes that surround the groin, then it becomes like 96%. So still good chances. But once it spreads even further past that lymph node region, that general region around the groin, then you start to get into the danger zone. So even though more people survive, I mean, which would you rather have, a 73% survival rate or a 99% survival rate? So this is why it's also very important in detecting cancers before it spreads too far. So it's very treatable if caught early. And why do I bring this up? Well, what's the age most at risk? Well, remember that prostate cancer is more seen in older men because why? Because the prostate increases in size with age, and that size also contributes to cancer. But testicular cancer, it's a disease that most affects males in the younger range. So there's probably a lot of you watching right now that are in this range. So this is why it's important to screen for testicular cancer, because it affects relatively young males. Now, this is why they encourage, especially at that age, to do testicular self-exams in the shower, and there is a way, there's many videos, and it's interesting because I don't think I've ever seen it here in the US, but in the United Kingdom, they have, like, there's a video, like, they got a rugby team on TV, and they dropped trowel, so it was only like lower half, but they were teaching them all how to do a testicular self-exam, and showing like, okay, there is a procedure, and basically you want to see like, okay, what's the texture of the testicles and what's your normal. And again, remember that cancers in general, they feel harder and they feel more dense than the surrounding normal tissue. So if there's all of a sudden a lump suddenly appears and you don't recall that lump being there to begin with, then that might be something you want to check up with. But the good thing is that if you feel a lump, does that mean you have cancer? Not necessarily. It's actually more likely to be some sort of like abnormal growth, or it could be like some sort of like condensed connective tissue, but you still want to get it checked in case it is cancer. But yeah, there's many, and I like this picture too because why? I mean, I think if I remember the open stacks, the thing is that testes, they are not the same size. Like in most men, there's a difference in the size. Like if one hangs lower than the other, that's actually pretty normal. Or if like one is bigger than the other, that's also normal. And that's not just in the male reproductive system, also in the female reproductive system. It's kind of rare that something looks perfectly symmetrical like they see in the anatomy books. There's all shapes and sizes. So this is what I'm getting at. Even though it's a cartoon, it shows that, yeah, testes are often different. Now, there's also something that can increase the risk of testicular cancer, and there's something called cryptorchidism. So I have a friend, like, and he said like he only has one testicle, and I don't know if he never developed the other one. And actually, I have two friends who knew, but of course I take their word for it. But the testicles develop initially in the abdomen during fetal development, and then what happens is that they migrate their way through the inguinal canal, and they move through the abdomen, and then they end up in the scrotum. So they don't start off in the scrotum and develop there. It actually has to migrate. So cryptorchidism is when it's like when you think of a crypt, it's not different from like the or like when you have encryption, that means you're kind of like encoding something and kind of hiding it away. So cryptorchidism is kind of like a crypt where these testes are being hidden away. So cryptorchidism is like sometimes these testes don't fully descend and end up in the scrotum. So I never done an ultrasound on my friend. I don't know if they have extra, or friends, I don't know if they have their extra testicle somewhere in there, but that's pretty typical. It's not that the testicle didn't develop at all. It's just that it never descended into the scrotum. So it kind of gets stuck in the abdomen, and it's interesting too because like this testicle is at increased risk of developing testicular cancer. So sometimes they might have to, if it is stuck there, they might do an ultrasound or see if it has it. Or sometimes they might recommend removal of it if they notice an abnormal mass developing in that testicle. But again, it's going to be hard to palpate and feel that testicle when it's in the abdomen compared to when it's in the scrotum. So yeah, does the non-descended testicles still produce hormones? Yes, and that's another reason why they think it's like the combination of body temperature and other things and the hormones. They think does that affect the hormonal production in that testicle, and that increases the risk of that undescended testicle to testicular cancer. And yeah, that kid from when the sperm will not be fertile because why? Basically, again, this is why we have a scrotum, trying to maintain the ideal temperature. So that testicle, that's undescended and stuck in the abdomen, if it does have sperm, it's going to be much less. There's going to be way fewer viable sperm compared to the one that's descended, because again, it's going to be held too close to the body. So there's going to be any developing sperm in there would be basically cooked. It's way above normal temperature for maintaining that relatively cool temperature, ideal temperature for sperm development. But yeah, why do I show this? Because I don't know, maybe it's like I lost contact with that friend, but he said like, oh, he claimed he was able to push down that testicle and back in his scrotum, or like the doctor did that to him, and so he had like two testes at one time, but it ended up migrating back. And I'm like, well, when I thought about it later, I'm like, yeah, I could believe that, because like unless there's something actually anchoring, and the doctor who pushed that testicle supposedly down in here actually anchored it to the scrotum and all the connective tissue there, yeah, there's nothing really anchoring it there. So we have all this tissue that anchors the testicles in place. But yeah, so undescended testicles increase risk of cancer due to multiple factors. So sometimes they recommend removing it. Now, especially if there's a mass. Now, polyorchidism, now this is very rare, also called supernumerary testicles. So numeral sounds like number, super is above. So that means testicles above in number. So typically 2 testicles, but this means having more. So extremely rare, only 100 per reported cases. So if someone has like polyorchidism, then they're kind of like, they make it into medical journal because it's like very, very rarely documented. And is there one with 4? There could be, but yeah, there was a post on Reddit, and I was trying to find the uncensored picture, and now you can find it. You can look up this picture there, like this post on Reddit, and I think the person deleted their account, and they also deleted the imager image. But when I saw it, I mean, I never did the physical exam, but I was like, that looks pretty, it was kind of amazing too, because all 3 testicles were pretty close in shape too and size. So it was like, wow, this looks like a legit case, because like sometimes there might be something called a hydrocele, which are swelling on testicles, and sometimes they think, oh, it's another testicle, but it's actually the accumulation of fluid and damage to the tissue. But yeah, there is some, but the thing is that with this, like people who have polyorchidism, these guys also they recommend the removal of the extra testicle, because they find that people with polyorchidism, they have an increased risk of testicular cancer compared to the males who have the regular number of testicles. So increased cancer risk. So sometimes even it's like, oh, even though it's a functional testicle, they might say, oh, let's remove it because of the increase of cancer. But so other factors include genetics. So things that the very interesting is like there's genetics. Okay, so there's a and this is based on NIH, like the NIH National Institutes of Health. They classify, like, this is the census categories. Like they say, okay, white, black, Native American, Pacific Islander, Asian, and Latino, and yeah, they have those 5 categories. But the interesting thing is not just genetics, because they found out that even if you don't consider those demographics in hand, highest risk among Americans, regardless of genetics and ancestral backgrounds, they find that Americans and Europeans have a higher risk of testicular cancer compared to continental Africa and Asia. So you could have someone who has black ancestry in America, they would have a higher risk of testicular cancer than someone in Africa who has ancestry from the same region, or someone from an Asian American from that same region. So like compared to my cousins in the Philippines and Okinawa, they would have a lower risk overall compared to me because I'm American. So it's both genetics and environment can play a factor. Now, what accessory gland or reproductive gland do males and females have in common? And it might be kind of fudging things by calling it a gland, but there is a reproductive tissue in common between the female and male reproductive system. And these are the mammary glands. Now, they're different arrangements post-pubertal, but men do have mammary tissue. But not very much, not as much as a biological female. But this is what we see with the mammary glands. So this is the female mammary gland. If we look at a side view right here, we see that there's the main mammary gland that can produce milk. And then this leads to the nipple over here. But there's also a lot of fat here as well. But not just fat, there's also connective tissue and ligaments. So what we see is like, okay, compared to the male and female mammary glands over here, so yeah, you have nipples and areola in both. But notice that these tissues called ducts and lobules are way more developed in the female mammary gland compared to the male. So the male men out there, you have the mammary glands, but assuming you haven't had surgery, so there's a tiny bit, maybe around nickel size on average behind here. So, but it's just not developed into all these ducts and lobules. And yes, there's fat as well. Now, if we look in the inside as well, what we see is like, okay, we have the pectoral fat pad, and that's a big hint on to what anchors and helps to form the base of the mammary gland. So we have the pectoral fat pad, and we have all these ligaments, suspensory ligaments, also called Cooper's ligaments. That's a common name. So these Cooper's ligaments, it's not just fat over there. It's not just ducts and lobules. these help to determine the overall structure and architecture of the breast here. So the pectoral fat pads give volume, but these Cooper ligaments, they're important in determining the shape. So like it's kind of funny, like when you look at people like draw like the mammary gland or breast, it's like sometimes they just draw a big circle or just like it's a sphere. I'm like, no, that's maybe if it's like, this is why like natural, like with it, assuming that there's no implants, sometimes it's teardropped and sometimes it's more pointy, sometimes it's more spherical. There's all sorts of shapes and sizes, and it's determined by not the volume via the pectoral fat pads, also the ducts and lobules, and also how many ligaments there are and how they're arranged and how they're inserting on this pectoralis major. And these ligaments can also stretch and change shape with age and gravity and weight loss and gain and pregnancy. So big changes in, like, especially weight loss and gain, that's going to change the volume of the pectoral fat pads. And that's also, if it gains volume, these are going to stretch the ligaments as well. So this is why the mammary glands can also change shape with like big weight changes and weight gain and loss. And how can you also prevent ptosis or sagging of this? Well, I mean, I have to update this because it turns out, like, I think they did a study and they said like it didn't really help out. But at one point they thought, like, because these suspensory ligaments are inserting here on the pectoralis major, that by building up the pectoralis major and those pec muscles, that by tightening it and kind of like increasing the tone of this muscle, maybe these would stretch out the ligaments more, so that this would help to be like a natural breast lift, because these would help hold up the suspensory ligaments even more. But I think I have to find that article again. I think it would be nice, like, yeah, you don't have to go under knife, you could just do a lot of push-ups. But I think the article didn't support that hypothesis, unfortunately. Yeah, but exercise is good in general. So like, even if it doesn't help with that part, at least you're getting, like, you'll be able to bench even more. But all right, so superficial anatomy. What we have here is a nipple, and this is a common misconception. Like, here we have a nipple, and here we have the areola. So the nipple is that initial raised part on the surface, and yeah, I know a lot of you probably know what a nipple is, but this is where those mammary duct glands or glands, the ducts of the mammary glands, open up into the external environment. And the areola, so they say like, oh, so-and-so has big nipples, when they're actually saying, I mean, maybe if this raised part was really big, yeah, they have big nipples, but they probably are talking about areolae. So areola is this pigmented skin. And is it always a different color? It's not unusual. I mean, actually, it's just like, it's pretty common that it's a different color compared to the nipple itself. But, or actually compared to the surrounding skin, yeah, that it's very typical that the areola is a different color. But who knows? It could be like the same. There are some people who have like the areola is the same color as the surrounding chest and breast tissue. So I mean, it all comes all color, shapes, and sizes. That's what I'm getting at here. So, but the main thing is, like, nipple and areola are not the same. So this is like, the nipple is that center part that's raised, areola is surrounding it. Now, some people might have these, and is this some sort of disease? So yeah, so areolar Montgomery's gland. So what we have is that this Montgomery's gland, this is not a disease. And you might notice that they're a little yellowish over here. So these are completely normal. If you have these, don't worry, you don't need surgery or anything, because these are normal. And the yellow color kind of indicates what there are. So these are oily secretions. And these oily secretions, like, say, like, okay, someone's nursing and they're breastfeeding, these also help to lubricate the nipples because again, when the baby is feeding, then that's going to potentially cause chafing. So these Montgomery glands and their secretions help to lubricate the nipples, and males have them too. So that's the interesting thing. This is, or I don't have the source, but yeah, this is a male nipple, trust me on that, and you can kind of see the stubble here. But Montgomery's glands are common in both, like, female and male. Yeah, they're not unusual. They're totally normal. Now, the thing is, like, okay, and this is where, like, the U.S. is kind of like, it's kind of funny, like, in Europe, like, on beaches, like, women and females can go topless if they want, and we're actually certain countries, like, I know, like, France and even the UK, they allow that as well. But yeah, so why do males have nipples? And this often comes, and things like just like female nipples, male nipples come in all shapes and sizes, or actually male areolas. So why do males, like here we have like relatively large areola, and then I was like, hard to say, like maybe it's the same color or something, but that's pretty small areolae. But why do males have nipples? And you might notice like, hey, there's something special about this. Alright, so then this also led to something else. So since this is a related question, that some articles, they say like, okay, everyone starts out as female, or we're like all born as female. And it's like, yeah, not quite. It's missing a sort of subtle point here. So it's not quite, because why? Well, things that genitals don't actually develop until 12, or not 12 weeks, but 11 weeks. So around 11 weeks, going from embryonic to fetal development, that's when genitals start to develop. So you don't start out for genitals. The thing is that before that point, totally sexless. There's no genital, or like genitals aren't fully developed into male or female genitals. Now, then we have to talk about chromosomes and karyotypes. So chromosomes, again, back to like the typical, here we have a normal male, human male karyotype with XY. So the thing is that this XY, like before this XY chromosome takes effect, this is what we have with the genital tissue over here. So it's not even male or female at this point. You have something called genital fold, genital swelling, and genital tubercle. These are indifferent because it's neither male nor female. But what happens at this point is like when if say it's an XY karyotype and the Y chromosome is functioning normally, well, XX, what happens is that this is the path these tissues will take. So you notice that this genital tubercle ends up becoming the glands of clitoris, and these swellings become the labia minora, and then the fold, or actually the fold becomes the minora, and the swelling becomes the majora. But if there's an XY and the Y chromosome is fully functional, then this ends up the fold ends up becoming the shaft of the penis, and the glands end up becoming the glands of the penis. So this is why we call them like corresponding tissues between the female and male reproductive system, because they start off from the same embryonic tissue. Now, yeah, I don't expect you to memorize this, but just saying that these pairs right here, they develop from the same embryonic tissue. Now, things that typically we have like, okay, XX develops into female, XY develops into male. And there's a gene on the Y chromosome called sex-determining region Y, or SRY, or sometimes called SARI. And like a common mnemonic, sorry, you're a male. So then that's what's it going to do? Well, it's going to it's kind of like the first domino in a series. It's going to not just tell the end result is that the developing fetus developing fetus ends up having male reproductive organs. But this is also interesting because what if something happens to the SRY gene? Well, if something happens to the SRY gene, and say it gets completely deleted or mutated or inactivated, where it doesn't produce that polypeptide and protein that is made by the SRY gene, then and this is in your slides, I had to censor it because like YouTube. But yeah, phenotypically is meaning in appearance. So these individuals have Y chromosomes. They all have Y chromosomes. But if you look at the pictures, just by superficial appearance, you would think they're female, right? So there's a female phenotype. So genetically male, but appearance-wise, and they also have like external genitalia that more resembles a female. And sometimes they all have a uterus as well, because something happened to their SRY gene. The Y chromosome is intact, but this part has been altered, inactivated, or deleted somehow. So this is an interesting thing. So or sometimes it's not just mutated, but deleted altogether. Same result happens. So if it's a mutation or deletion, even though there's a Y chromosome, if that SRY gets affected, then we have a reversion back to a female appearance and phenotype. There's also something called Swyer syndrome, and this was an interesting case study where there's a 36-year-old patient that was had XY chromosomes, but the thing is that they were able to actually do a successful in vitro implantation, and they worked with the endocrinologist. They were able to so they fertilized the eggs, if I recall correctly. They were able to make there was a lot of hormonal preparation with estrogens and progesterones, and then to maintain that endometrium. and then they implanted the embryo. And this is why it's rare, because it sounds like a very delicate, complicated, expensive operation, but they were actually able to carry to term. So that was pretty amazing. So XY female, and this is why it's like also very important to understand those hormones. But back to the chromosomes and whatnot. So things that we also have sex hormones in play as well. So we have like estrogens and progestogens, and we have androgens as well. But what if something blocks them, or say like you don't produce enough of these hormones in these individuals, or something happens to the receptors that detect these hormones? Well, what happens is that you could end up with these embryonic tissues not really developing into male or female. So what happens is like something called gonadal dysgenesis. So ambiguous genitalia, there's the uncensored one in your slides. And then they develop something called streak gonads. So these aren't testes, these aren't ovaries, and they don't have gametes. So it's gonadal tissue, but never really became male nor female. There's no ova, there's no sperm. So this is why it's like these people are living, they're there, but it's like can you really say male or female reproductive system in this case? So things that it's not just about chromosomes, it also is like whether the genes on those chromosomes are functional, and also like other things like endocrine system, like if their hormone, like the primary female or male hormones actually do have an effect in these individuals. So the interesting thing is that nipples and areola, back to the topic, is that they're essentially the same at birth. So the thing is that the whole thing that everyone starts out as female is like, okay, when you have an initial zygote, embryo, and fetus, these are initially sexless before 11 weeks. But the SRY gene is important, and other genes can affect maleness. Like there's something called DAX1. If you have 0 copies of DAX1, then you end up looking like a phenotypic female. If you have 2 copies, you'll end up looking like a phenotypic female by default, even if you have a Y chromosome. So it's not just SRY, but that's a little beyond this class. So a better explanation is not that everyone starts out as female, but female by default. So if something happens to SRY, or something happens to androgen sensitivity or androgen receptor, that's why someone could have a Y chromosome but look like a female, because something happened with the endocrinology, or something happened with the genetics. All right, true or false? Maybe answer this at home on your own time. So males have mammary tissue. Hopefully you know from that previous one. Yes, males have mammary tissue. And then true or false? The female breast reaches peak development immediately after puberty ends. So 3, 2, 1, pause if you're watching at home, but this is false. So things that these milk lines, these appear even before genitalia happens. So these are embryonic tissue, and they develop before that 11-week period. So this is why males have nipples. These milk lines develop before them, and they can end up developing into nipples. Now, notice that there are multiple nipples here, and is this just a weird picture? Well, things that most of these supernumerary, so remember like supernumerary testicles is extra testicles. So these extra nipples end up doing that apoptosis, that's programmed cell death. So they end up being removed by your body before you're even born. But here we have Harry Styles, and if you look here, like he has 4 nipples. And why is that? He has supernumerary nipples because these didn't end up undergoing apoptosis before birth. And again, so yeah, he has 4 nipples, and it's confirmed. Like you get the multiple pictures here. And then Mark Wahlberg, when he used to take off his shirt, like back in the day or whatnot, so like he like here you can see his 3rd nipple, kind of like corresponding to like Harry's over here on the left. And yeah, it's funny because like look at this, like I think they probably photoshopped this one here, because like unless he had it removed for some reason, like yeah, it's like that's not a mold, that's actually his nipple there. But yeah, supernumerary nipples, this is due to those like nipples not undergoing apoptosis and removal by the body. All right, so before puberty, how do the mammary glands develop? So estrogens and progesterone are very important in the development of those ducts and lobules in the mammary gland. Now androgens, on the other hand, in the male reproductive system, so we have a surge in estrogens and progesterone during the menstrual cycle and female puberty. In male puberty, androgens increase. But the thing about androgens is that they inhibit the growth of ducts and lobules. So this is why males have smaller like mammary tissue compared to females, because the androgens are suppressing that. But this is also why, like, when you have that surge of androgens during puberty, that's why some teens, they can develop gynecomastia, because remember that androgens can be converted to estrogens via aromatase. So if you have too much androgens, that can also cause the increase in estrogens that cause breast tissue to develop. That's also why, like, bodybuilders who abuse anabolic steroids, especially androgens, they can end up, or I shouldn't say abuse, but if you take too much androgens and don't take other things that prevent the conversion of estrogens, that's why some bodybuilders, they end up actually having hard masses of breast tissue, because the excess levels of estrogens overwhelm the androgens and cause the development of the lobules, ducts and lobules. But this is what, back to normal puberty right here. So puberty in the female body, what happens is that estrogens and progesterone are going to promote the development of ducts and lobules inside the mammary gland over here. And eventually that results in the increase in volume due to the branching of all these ducts over here. And also these lobules are starting to grow as well. So the basic functional units of the mammary gland are ducts and lobules. So ducts are the ones that carry milk, and the estrogens stimulate the development of these ducts and also the lengthening of these ducts as well. Now lobules, these produce milk. So progesterone is going to stimulate the branching of the ducts actually, and also the formation of these lobules. So these lobules are like little pockets of cells that help to produce milk, or that do produce milk, and these pockets are called alveoli. So different from your lung alveoli, but they're kind of similar. Like, they look round and they're like kind of like vessels, round vessels that contain something. In this case, it can carry milk and produce milk. So alveoli, they produce milk, ducts carry milk. And both estrogens and progesterones are important for the formation of ducts and lobules. So these are the ones that actually do the lactation and milk production. Now with the post-pubescent mammary gland is like, okay, now you have increased amount of ducts and lobules. So this is what a big driver behind the reason why there's development of the breast and mammary glands during puberty. But is it done at this stage? So the breast is actually not fully developed at this point, and something else has to happen. What has to happen is that this needs to happen. So here we have an ovum, and here we have a corona radiata, and here's a sneaky old sperm fertilizing the egg. So say you have successful implantation and you're carrying to term. So what's happening is now we have a fetus that develops embryo that develops into fetus and develops into a baby. So now what's going to happen to hormone concentrations is that during this pregnancy, estradiol and progesterone is going to go, like, this is like maybe like the relative peak compared to the menstrual cycle. It's going to go through the roof. These are going to increase even more. So with more estrogens and more progesterone, you have increased breast development. So this is why during pregnancy, this is why the breast reaches its maximum size. So it's very typical and normal for the breast to increase in size and during pregnancy. So this fully developed then, and then after, like, okay, weaning happens and you're no longer breastfeeding, then what's going to happen? Okay, you don't have that high levels of estrogen and progesterone. So something called involution happens, where the breast tissue starts to decrease in size because now you don't have the high levels of estrogens and progesterone maintaining the ducts and lobules. So things that so lactiferous ducts, these are large chambers that contain these lactiferous sinuses. So it's easier to explain here. So what we have are like all these lobules, and they lead to this kind of like reservoir. So it's like it's not like a constant, I mean, depending on the volume of being produced by a female, you can have but this is how the breast is able to store milk, is like you have production, but you also have these like ducts and sinuses that help to store it as well. So lactation, what happens is that you also have an increase in prolactin that stimulates the production of milk, and you also have an increase in oxytocin as well. But what happens is, like, okay, after giving birth, what happens is that the estrogens and progesterones drop off, but prolactin stays up there. So this is why, like, as long as you're feeding and breastfeeding over there, that's why this will be maintained, and prolactin, and you still have lactation. But once you stop that cycle of breastfeeding and lactation, that's why it starts to drop off, because you have that positive feedback we talked about earlier in the semester. All right, so now let's end up with breast cancer. So the thing is that breast cancer can be there's actually multiple ways to categorize it. So the main 4 categories, like there's actually other subcategories as well, or other types. So there's ductal breast cancer, and where do you think they develop? They develop in the ducts that carry milk toward the nipples. Now lobular is going to occur and develop from the alveoli that are found in the lobules. So instead of being in the ducts, you have a cancer here. So those are 2 main categories, but it's also further combined with other categories. So you have in situ versus invasive or metastatic breast cancer. So in situ is Latin for in place. And so this is like a cancer that's there, but it's stuck in that place. So it hasn't gone past its borders yet. But when you have invasive and metastatic breast cancer, that's when it starts to spread past its original area, and it can end up in lymph nodes or end up migrating to other parts of the body. So you can actually combine these categories. So you can have ductal carcinoma in situ, you can have invasive lobular carcinoma. So these are 4 big categories of breast cancer. Not all breast cancer neatly falls into these categories, but these are a lot of the cases. They can be classified into this system. There's also something called inflammatory breast cancer, where it's not really localized and doesn't really fall into those categories, and it's still being researched. I have to look up a review on it, but it's aggressive, and it's like, okay, inflammation is also not only important in immune defenses, but a lot of inflammatory molecules also increase cell growth. So what inflammation and cancer is kind of like is a very bad news, because inflammation drives the growth of cells, and if you have cancer cells that are gobbling up the inflammatory molecules and signals, that they can see that, oh, this is like adding fuel to a fire. That's why inflammation and cancer is a deadly mix. Now, this is why it's also important to detect breast cancer as well. So there's many things and this is why it's also important to know what's your normal. It's like not whether what you are compared to someone else, but it's like, okay, this is like if you have what we have is like different changes in the areola or nipple or things surrounding the breast. And yeah, so inward nipple, that's very interesting. Like sometimes due to changes in the ligaments and shapes and how the connective tissue, sometimes you can have a nipple ending up poking back into the breast, or discharge if you're not pregnant, or skin thickening, or pain, redness. Those are often things. And I like this little thing, right, this sign here. So it's showing you the little analogies between a breast and changes that might occur during breast cancer, like orange peel skin. Initially they call it peau d'orange, but I think that's in French. But yeah, this is like showing it's like becoming rough and bumpy and having all those like little divots, like the peel of the skin, sunken nipples, and new shape or size. I mean, look at it. I mean, it's but so many things. That's why it's important to know what your normal is for your reproductive organs. Now, there's different breast cancer screenings over here. So there's self-exams, there's partner exams, and again, especially for like female reproductive health, like if you're not comfortable with a male practitioner, you can request a chaperone, or if they can't get a female, or you can request a female chaperone if you're not comfortable with just a male practitioner by themselves. And again, it's only from the waist up too as well. So there's advantages, disadvantages to doing that as well. And another thing is like physical exams, they might help. They just do this at random? No, it's like maybe if you're like it's all about screening and early detection. They also might do a mammogram if you have like a history, or if you're in the age range that's most at risk of breast cancer. So they're basically taking an x-ray, and yes, these mammograms, they have to do horizontal. So this is, look at this. This is actually compressing it, because why? Well, this is also because the breast tissue is like, it's not flat, like not like this, like we're showing here, but it's just trying to increase the clarity of that image. So they are trying to find ways that are less painful, because yeah, you're getting pinched over there. So that's why they're trying to look for these abnormalities and dense growths, because again, tumors tend to be dense compared to the surrounding tissue. And they also might do a lymph node check, because why? You have these armpit lymph nodes, and say you have metastatic breast cancer, and these initial tumor cells find their way into the lymph ducts and capillaries and ducts, and end up at the lymph nodes. They can sometimes end up growing in the lymph nodes and forming these hard masses. So that's one way they check, if you like. Or they might end up doing removing part or some of the entire lymph node to see if there are cancer cells in there. So the thing about, because remember that progesterone and estrogens are very important for development of ducts and lobules, this is why they also will look at whether you have receptors for that in the breast cancer. So estrogen receptor and progesterone receptors, these are common things that pathologists look at to see, okay, is the cancer kind of taking advantage of these hormones and using them to grow? There's also something called HER2, which is a receptor. It's a little more complicated than just a simple hormone. Don't worry about for this class. But the thing is that there are drugs that target these receptors. So say the female has breast cancer and is estrogen receptor positive, they might give a drug that targets the estrogen receptor and inhibits it so that the cancer doesn't grow as fast, because now it doesn't have the advantage of estrogen promoting its growth and cell division. But the thing is that there's sometimes triple negative breast cancer, and this is kind of scary because when you have triple negative breast cancer, you can have an anti-estrogen, you can have something that affects anti-progesterone, you have something that attacks the HER2 receptor, but if you're triple negative, you can't use those drugs. So that's why for triple negative breast cancer, they're saying okay, this breast cancer has none of these. That's why they typically go for general chemotherapy that kills dividing cells in general. So it'll kill cancer cells, but it'll also kill normal cells as well. So that's why people undergoing general chemotherapy for breast cancer, they might have hair loss, they might have digestive problems. It's because the chemotherapy is killing the cancer cells, but it's also affecting normal cells as well. So risk factors, most diagnosed with women or females over the age of 50, and genetics, family history. So if you have an immediate relative like a mother or your sister with breast cancer, your relative risk compared to the general female population is increased. Now, does that mean you will develop breast cancer? Not necessarily, but it means okay, maybe you should have more regular screenings because you have that increased risk due to genetics and family history. And ancestral background too, so also depending where you have ancestry can also affect that as well. So there are disparities. This is one of the problems with the whole NIH classification. They lump Asians and Pacific Islanders in the same average, but sometimes you find out if you're looking at certain regions and certain countries of ancestry, then you find out that sometimes you have increased risk of these cancers. So it's not just breast cancer, but this is an example. So what we saw is not only that compared just the general Asian population in LA County, they saw Filipinas were having increased risk of breast cancer compared to women who are of Chinese or Japanese ancestry. Now, the other thing is that menstrual months also matter as well. So age of menarche and menopause. And why does that matter? Well, the thing is that menarche is when you start having the progesterone and estrogen, right? And remember that estrogen and progesterone also increase breast development. Menopause is when you stop having menstrual cycles due to having a lack of ovarian follicles. So if you start earlier, here, pretend this the total amount of menstrual cycles. If you start earlier and end later, you have more months of estrogen and progesterone exposure. So this is why starting having younger age of menarche, when you start a period, and the later menopause also increases that as well. And also pregnancy, whether there's a late pregnancy or never being pregnant in your life, that also affects breast cancer because again, estrogens and progesterone. And it's still the most common non-skin cancer in women, but now thankfully with all the research and therapy and increased awareness and screening, it's no longer the deadliest cancer in women. It's now second deadliest, and what's overtaken is actually lung cancer. So lung cancer is now the number one killer in women. And can men get breast cancer? Can males get breast cancer? And yes. So this is I know how to say it in French, I think, but how do Marines say it? I think it was Lejeune or something like that. They say that. But that Marine-based Base Camp, what they found out is that there are pollutants being leaked into the drinking water. And things that carcinogens can, if they end up in drinking water, can actually they can cause the development of breast cancer. So these Marines were developing breast cancer because of these contaminated drinking water containing carcinogens, and these carcinogens were affecting the breast tissue that they have, very small initially. And they end up finding, like, I think if I remember one of the articles, he said, like, I started having discharge, and it's like, yeah, he's definitely not pregnant, but it's like, yeah, abnormal discharge. Or I've heard of like involution as well, where the outie nipple ends up becoming involuted and inly, so abnormal changes as well. And this is one of the Marines that ended up going a mastectomy, so I think they removed a lot of his pectoral as well because he developed breast cancer in the right pectoral and mammary glands. So yes, in rare cases you can have male breast cancer due to carcinogens, or even like hormone therapy can also affect that as well, because again, the tissue is there, and if there's enough estrogens, carcinogens, or progesterone in the male body, that can cause the development of breast cancer. All right. Okay, so let's see. Yeah, and it doesn't look like there's any questions on the review session yet, so I'll remember, don't forget about the Top Hat exam 3 review session facts. So I'll check it during and prep things for Friday. So Friday, same time, 1:30 to 2:20, I'll do a review session. And if there's not enough questions on the fact, then I'll also maybe try to like drum up some practice questions and talk to you about how to walk through those practice problems as well. Kind of like similar like I did for exam 2. All right. Okay, so I know I get over time, but as you can tell, I mean, this is actually the whole reason why I got started. Yeah, and Packback, if you're not already done with Packback, you can still finish it up this week. And you know what? If you want to do Packback during finals week, you can do that as well. So yeah, I mean, it's tough, like in this stupid pandemic. I mean, I'm really cautiously optimistic. I can't wait until to return into person as well. But I know even then, like, we still have an online section next semester because who knows? Like, I'm just hedging bets, like, in case we do. I won't even say it, even think about it, and speak into truth. But let's end on a positive note. And like, yeah, so this is why this is why I'm so passionate about this. Like, cancer has affected my family, probably has affected your family. I mean, if your family hasn't been affected by cancer, you're very fortunate. But yeah, this is why I actually started becoming a scientist and started researching this stuff. And I mean, and this is, as you can tell, I really like this semester because we talk about internal medicine, all my favorite systems of the body. But for those of you, and I know there's a bunch of you, and I wish I could do a shout out, but the people in like legal, they say like, oh, you can't say like names on if you're doing a live class public. But thank you for those of you who've been watching every day. I really appreciate you. I really appreciate everyone who participated in these activities as well. And I mean, regardless of grade, give yourself some credit. And that's why I wanted to end with that nice wrap up, because again, just like getting through college, learning this stuff for the first time, especially if this is, or heck, even if it's your second time, welcome back. You're showing dedication to things. So by all means, thank you for attending. Thank you for this semester. And I really hope you do well with finals week. All right. So take care and see you on Friday if you're attending the review session. All right. Hui ho for now, and see you maybe soon. Hey, want to say hi? Yep. All right. Yeah, see, the class wanted to say hi. I know you don't like studio lights, but yeah. All right. Okay, and Mr. Peanut is saying hi, bye for now. And he's like, yeah, this is too bright for me. All right. Bye, everyone.